Location and anatomical relationship to other structures are important in deciding the approach to biopsy. The effect of respiratory and cardiac motion on lesion movement should be taken into consideration. The type of biopsy and amount of tissue required are also important. Central endobronchial or peripheral airway lesions with airway leading to the lesion are best suited for the bronchoscopic approach rather than CT-guided percutaneous biopsy. Contraindications are a non-cooperative patient, significant respiratory compromise or hypoxemia, use of positive pressure ventilation, interstitial lung disease, lesion located along the diaphragm or close to the major blood vessels, or having coagulopathy. A platelet count and coagulation profile should be obtained before the biopsy, and chronic anticoagulation and antiplatelet therapy should be withheld on the basis of its pharmacokinetic property. The patient's positioning or for the procedure depends on the approach and the location of the lesion. Bronchoscopy is generally performed in supine position, while CT guided can be supine lateral or prone position. Prone positioning has the benefit of wider intercostal space and relatively less respiratory motion. Needle sizes vary, and most of them have an end cutting or side cutting technology. Core needle biopsies provide greater material for a histopathological examination. Additional studies are required compared with fine needle aspiration. This is the CT guided percutaneous biopsy route of which is for the left lower lobe nodule. Bronchoscopic techniques for lung biopsy. Uh, First one is flexible fiber optic bronchoscopy. It is used to directly visualize the trachea and proximal bronchi, as well as to assist in the diagnostic workup of lung disease, including lung cancer and infection. On the left hand side image, it is the flexible fiber optic bronchoscope, and the right side, the tip is visible. It has two light source, one camera port, and one suction port. Endobronchial biopsy. Visible lesion within the trachea or bronchi may be biopsied endobronchially using forceps of different sizes and type. The forceps are passed through the working channel of the bronchoscope, and then sample of nodules or mucosal abnormality may be taken under direct visualization. The use of a narrow band imaging and autofluorescence during bronchoscopy can enhance the mucosal lesion. In this image, we can see endobronchial biopsy technique near the carina and endobronchial lesion using flexible forceps. Bronchial brushing, it works as a It works by agitating the bronchial mucosa, which exfoliates cells that are then retrieved and tested for cytology or microbiology. A bronchial brush is advanced to the working channel of the bronchoscope and scraped along the bronchial mucosa at a desired site. This is the image of the flexible bronchial brush used for endobronchial and transbronchial brushing through the flexible fiber optic bronchoscope. Transbronchial lung biopsy performed with the help of biopsy forceps that are advanced through a bronchial valve and out into the periphery of the lung area. Lung to areas not directly visualized with the bronchoscope. This biopsy is frequently performed under fluoroscopic guidance. The procedure is performed by advancing the bronchoscope and wedging it in the desired segment. A biopsy forceps is passed through the working channel and then advanced under fluoroscopy into a localized lesion or a peripheral lung tissue. Pneumothorax and bleeding are the most common complication after the procedure, mostly 1 to 5%. Hemostasis is assisted by maintaining the bronchoscope in its wedge position for at least 1 minute following biopsy. This is the image of flexible forceps used for endobronchial and transbronchial biopsies through flexible fiber optic bronchoscope. Transbronchial needle aspiration performed for central lesions and lymph nodes that lie just outside of the bronchial valve, as well as the peripheral lung lesions that are not visible through the bronchoscope. Peripheral lung nodule sampling is often guided by combined fluoroscopy and radial endobronchial ultrasound to confirm localization to a target lesion. A transbronchial needle can also be used to inject dyes, medications, glue, etc. in central or peripheral lesions. First image is the transbronchial lung biopsy under fluoroscopy guidance, and the second and third images are the transbronchial needle aspiration of the left lung nodule under fluoroscopy guidance. Radial endobronchial ultrasound guided biopsy. A rotating ultrasound probe affixed to the flexible catheter that is advanced to the working channel of the bronchoscope. The probe spins when activated and produces 360-degree ultrasound images of surrounding lung tissue. The tip of the ultrasound probe also has electromagnetic position guidance to enhance the positioning of the probe within the center of the lesion of interest. Once a diagnostic target has been identified, the site is marked on fluoroscope or by using a guided sheath. Biopsy forceps, transbronchial needles, or other tools may then be advanced through this location for sample collection. Newer thin or ultra thin bronchoscopes with small outer diameters of approximately 4 mm and 3 mm respectively can be used in conjunction with radial ultrasound to reach smaller and more peripheral airways directly. Bronchoalveolar lavage is a technique of obtaining cytological or microbiological specimens from peripheral segment of the lung. The bronchoscope is first wedged tightly at the orifice of the desired segment to isolate it. Sterile saline is then instilled through the working channel into the segment of the lung in aliquots of 30 to 60 ml, generally to a total volume of 220 ml. However, a volume of 300 ml has been established as safe. The diagnostic yield for bronchoalveolar lavage in malignancy is 70%. If there is a visible lesion in the selected segment, and as low as 25% if there is no visible lesions. Electromagnetic navigation bronchoscopy. The use of ENB has been described to reach tumors located in the periphery of the lungs where smaller bronchi are not wide enough to allow passage of a normal bronchoscope. This is how with the electromagnetic navigation bronchoscopy with the help of fluoroscopy figures and in a virtual pathway we can see it. Rigid bronchoscopy. Since the advent of flexible bronchoscope, the rigid bronchoscope is currently relegated to more specialized indication. A rigid bronchoscope consists of a rigid hollow metal tube with a beveled edge, inner diameter ranging around 7,213 millimeter and outer is around 80 to 114 millimeter, equipped with light source and camera. The proximal end has attachments that allow for conventional or jet ventilation. A rigid scope provides a large working channel, allowing the use of larger instruments for interventions such as ablation, tumor debulking, and stent placement. Novel techniques for diagnosis of lung nodules, augmented fluoroscopy. It overlays 3D images onto real-time fluoroscopic images. Two navigation systems used for augmented fluoroscopy are Archimedes and Lung Vision. Archimedes system provides bronchoscopic transparenchymal nodule access. The BTPNA involves the creation of a tunnel to the parenchymal nodules using a sheath. Thus, it doesn't rely on a bronchus sign. The tunnel extends from a point of entry in the airway wall through the lung tissue into the pulmonary nodule. And in lung vision, this uses augmented fluoroscopy to highlight the lesion and airways leading to it. A pathway is planned based on a pre-procedure CT. Next, navigation with a catheter is performed under fluoroscopy using an overlay of the pathway and the target. Cone beam computed tomography. Cone beam, this allows registration of 3D datasets for real-time instrument localization. The 3D dataset is generated from a rotation of an X-ray source and flat detector that is integrated into an angiography or fluoroscopic suite. The target is defined on an intra-procedural CVCT and co-registered with live for fluoroscopy for 3D reconstruction. This allows the operator to view fused images during fluoroscopy for guidance with navigation. CBCT has been successfully used for transthoracic needle biopsy of pulmonary nodule. This is the setting of a cone beam computed tomography with augmented fluoroscopy combined with electromagnetic navigation bronchoscopy for biopsy of pulmonary nodule. Robotic bronchoscopy. There are two robotic assisted bronchoscopy systems approved by US Food and Drug Administration. One is Monarch, one is Ion. The outer sheath of the Monarch robotic endoscopy system is 6 millimeter and the inner bronchoscopy is 4.2 millimeter with a 2.1 millimeter working channel. The outer sheath is packed in the direction of the targeted bronchus and then the inner scope is independently advanced. The platform uses electromagnetic navigation and provides real-time visualization. This image is the Oris Monarch robotic system and navigation to a lung node. The iron is a shape-sensing robotic bronchoscopy system. The outer diameter of the articulating flexible catheter is 3.4 millimeter and the working channel is 2 millimeter. The catheter contains a shape-sensing fiber to provide a position and safe feedback. A video probe is used while driving the catheter but is removed in order to pass the biopsy tool. Invasive mediastinal staging, endobronchial ultrasound, and endoscopic ultrasound. These are include flexible bronchoscopy with the integration of the endobronchial ultrasound or bronchoscopy. It has increasingly become the dominant approach to evaluate the mediastinal and hilar lymph nodes for staging. EBUS bronchoscopes allow for the evaluation of structures just outside the airway, including lymph nodes, great vessels, and even primary tumor that are adjacent to the central airways. Uh, this uses a 7.5 megahertz curvilinear ultrasound probe that enables simultaneous visualization and sampling via fine needle aspiration or core needle biopsy. Pleural-based procedures. Pleural procedures can provide important information to assess the diagnosis and staging of lung cancer. Most patients considered for pleural procedures present with pleural effusion or evidence of pleural studying on pre-procedural imaging. Thoracocentesis, a needle or catheter is inserted into the pleural space between the lung and the chest wall to sample or evacuate fluid. Thoracocentesis should be performed as a first step in diagnosis for patients with suspected lung cancer and pleural effusion, as the presence of malignant cells in the pleural space is indicative of a at least stage 4A cancer and will immediately guide prognosis and treatment. This should be performed under ultrasound guidance to avoid injury to surrounding structures. Relative contraindications are coagulopathy, renal failure, or positive pressure ventilation, which may increase the risk of pneumothorax. Malignant pleural effusions are usually exudative with elevated fluid protein, lactate dehydrogenase level, and lymphocyte predominant, low in glucose and pH also low. Diagnostic yield for malignancy is variable from 62 to 90% in thoracentesis. Closed pleural biopsy. Percutaneous blind closed biopsy of the parietal pleura carries a diagnostic yield of approximately 50%. Traditionally, reversed beveled needles like Abraham's needle or Cope's needle have been used for closed pleural biopsy. The involvement of the parietal pleura is often more focal in metastatic disease as compared with visceral pleura, where it is more diffuse. Thus, the yield of a closed pleural biopsy is enhanced with imaging assistance. Thoracoscopic pleural biopsy of the pleura under direct vision can provide a diagnosis with high degree of sensitivity, specificity, and negative predictive value. This is the ultrasound imaging performed for locating access site for ultrasound guided thoracocentesis. This is the image showing pleural space in first image, and second image is showing how pleural biopsy performed with use through a flexible forceps. Immunohistochemical markers. Squamous cell carcinoma positive for cytokeratin AE1, AE3, CK56, CK7. Adenocarcinoma is positive for cytokeratin cocktail CK7, TTF1, AE1, and AE3, and neuroendocrine markers rarely positive, which are CD56 and NS. In large cell carcinoma, cytokeratin TTF1 rare, and neuroendocrine markers like CD56 and NSA. Large cell neuroendocrine carcinoma markers are cytokeratin cocktail AE1, AE3, TTF1, CD56, chromogranin, and synaptophysin. Small cell carcinoma cytokeratin cocktail tends to be patchy, TTF1, CD56, chromogranin, and synaptophysin. Next is genetic the correlation with the carcinoma. Adenocarcinoma oncogene is EGFR, KRAS, and ALK. Tumor suppression genes associated are TP53, CDKN2A or B, P1, PN6 and P1, PI4, LKB1. Squamous cell carcinoma oncogenes are EGFR, PIK3CA, IGF1R. and tumor suppressors are TP53 and TP63. Small cell carcinoma, MIC and BCL2, and TP53, RV1 and FHIT. This is the newer TNM staging, which includes T for primary tumor, TX primary tumor cannot be assessed, T0 no evidence of primary tumor, T in situ carcinoma in situ, T1 tumor surrounding by lung or visceral pleura or in a lobar or more peripheral bronchus, T1 MI minimally invasive adenocarcinoma, T1A tumor size less than 1 centimeter, T1B from 1 to 2 centimeter, and T1C more than 2 but less than 3 centimeter. T2 involves tumor with any of the following features, like T2A is tumor more than 3 centimeter to less than 4 centimeter, inverts visceral pleura, inverts an adjacent lobe, involves main bronchus, or it may be associated with atelectasis or obstructive pneumonitis extending to the hilar region involving either part of the entire lung. T2B tumor size more than 4 but less than 5 centimeter. T3 tumor with any of the following features, like more than 5 centimeter but less than 7 centimeter. Inverts parietal pleura or chest wall. Inverts pericardium, phrenic nerve or azygos vein. Inverts thoracic nerve roots or stellate ganglion. Separate tumor nodules in the same lobe as the primary. T4 includes tumor size more than 7 centimeter in greatest dimension. It inverts mediastinum, thymus, trachea, carina, recurrent laryngeal nerve, vagus nerve, and esophagus and diaphragm. It inverts also heart, great vessels, supraaortic arteries, and bronchocephalic veins. Brachiocephalic veins. Inverts subclavian vessels, vertebral body, lamina, spinal canal, cervical nerve roots, or brachial plexus. Separate tumor nodules in a different ipsilateral lobe than that of the primary. In regional lymph nodes, NX is regional lymph nodes cannot be assessed. N0 no regional lymph node metastasis. N1 is metastasis in ipsilateral, peribronchial, and or ipsilateral hilar and or intrapulmonary lymph nodes, including involvement by direct extension. N2 is metastasis in ipsilateral, mediastinal, and or subcarinal lymph node. N2A single N2 station involvement and N2B multiple N2 station involvement. N3 is metastasis in contralateral mediastinal, contralateral hilar, ipsilateral or contralateral scalene or supraclavicular lymph nodes. M is distance metastasis, M0 no distance metastasis, M1 distance metastasis present, M1A tumor with pleural or pericardial nodules or malignant pleural or pericardial effusion, separate tumor nodules in a contralateral lobe. M1B is single extrathoracic metastasis in a single organ system. M1C is multiple extrathoracic metastasis. It is it also divided into two, M1C1, which is multiple extrathoracic metastasis in a single organ system, M1C2 is multiple organ system. This is the nodal definition, ninth edition, which is no level 1 low cervical, supraclavicular and sternal nodes, level 2 upper paratracheal nodes, um, level 3 prevascular and retrotracheal nodes, and level 4 is lower paratracheal nodes, level 5 subaortic outer pulmonary window. Level 6 is para-aortic nodes ascending out and phrenic nerve. Level 7 is subcarinal nodes. Level 8 is paraesophageal nodes below carina. Level 9, left and right both pulmonary ligament nodes. And level 10 is hilar nodes. Level 11, interlobal nodes. And level 12, lobal nodes. 13 is segmental nodes. 14 is subsegmental nodes. This is the staging of the lung carcinoma. Uh, stays based on the TNM finding, that is stage 1 A1 is only T1 of any category with N0, 1A2, 1A3 all are same depending on the T1, and in stage 2A, 2B, and stage 2A is including T1 along with N1 or T2 with T2B with N0, and stage 1B is T2 with N0, T2A, T2B with N0. And stage 2B includes T2, any stage of T2 with N2A, T1 with N2A, and T3 with N0. And stage 3A includes stage T1 with N2B, T2 with N2A, T3 with N1, or T3 with N2A, or T4 with N0 or N1. Similarly, stage 3B includes T1 with N3, T2 with N3, T2 with N2B, T3 with N2B, or T4 with N2B, or T4 with N2A. And 3C includes T3 with N3 and T4 with N3. Stage 4A includes with metastasis M1A and M1B. Stage 4B includes M1C and M1C1 and M1C2. Treatment approaches to lung cancer: surgical management, chemotherapy, radiotherapy, immunotherapy, palliative options. Surgical management: resectability is determined by patient fitness to undergo surgery and tumor characteristics. Appropriate tumor staging, especially mediastinal nodal involvement, is fundamental to surgical planning. For stage 1 and stage 2 non-small cell lung cancer, resection is the best validated treatment option with the aim of cure. Operability is based first on the risk, immediate perioperative and postoperative complications, and second on the risk of long-term disability after resection of parts of the affected lung. Preoperative evaluation includes PFT. It includes forced expiratory volume FEV1. It has traditionally been considered the key component of the preoperative testing in patients scheduled to undergo lung cancer resection. It, FEV1 measures pulmonary reserve that also correlates with the significant of respiratory impairment associated with COPD. FEV1 is an independent predictor of pulmonary morbidity and cardiovascular complications after pulmonary complications, and that FPP1 60% represents the best cutoff for predicting increased incidence of lung complication. According to the American College of Chest Physicians, they currently recommends that both the preoperative FBP1 and the DLCOP measured with the subsequent calculation of the predictive postoperative value. FBP1 and DLCO 60% predicted, no further testing required. If either value is 60% but both are above 30% predicted, a load technology exercise testing should be performed, which include either stair climbing or shuttle walk test. If there is predictive value of FPB1 and DLCO is 30%, then a cardiopulmonary exercise test should be performed with measurement of maximal oxygen consumption, which correlates with the level of work achieved and is associated with postoperative complications. If maximal oxygen consumption is 10 ml per kg per minute or 35% predicted on cardiopulmonary exercise test, the patient should be counseled regarding a limited resection or a non-operative therapy. Such patients should also be considered for preoperative and postoperative pulmonary rehabilitation. Estimation Estimation of cardiac risk. The risk of major cardiac events defined as the occurrence of ventricular fibrillation, pulmonary edema, complete heart block, cardiac arrest, or cardiac death during admission. It has been reported approximately 3% after major anatomic lung resection. Two organizations have produced guidelines on the evaluation and treatment of the cardiac risk factor. These are the European Respiratory Society or European Society of Thoracic Surgeons and the American College of Chest Physicians. According to the American Heart Association guidelines, 7 non-invasive cardiac evaluation is recommended for patients with limited capacity for exercise and those with the RCRA of more than 1.5 and those with a known of newly suspected cardiac condition to identify the relatively small proportion of the patients who need intensified intervention to control heart failure or arrhythmias or to treat the underlying myocardial ischemia. Appropriately aggressive cardiac interventions should be instituted before surgery only for patients who would need such intervention irrespective of the planned surgery. Exercise testings include 6-minute walk test, shuttle test, and stair climbing test. These are used for preoperative workup for candidates for lung resection. These are can be used to assess the entire oxygen transport system and to detect possible deficit that may predispose to postoperative complications. A 6-minute walk test is an analytical exercise used to assess functional exercise capacity and monitor the progression of illness such as COPD and emphysema. During this test, the patient peripheral saturation level and perceived breathlessness or fatigue are monitored while they are instructed to conduct a brisk walk for 6 minutes, followed by a monitored recovery period for 3 minutes. The results are then marked against the predicted value for someone of their demographic age and stature. For healthy adults, the average 6-minute walk test distance is typically between 400 to 700 meters. A change of 14 to 30.5 meters is considered minimal clinically important difference for individual with cardiopulmonary disease. The 6-minute walk test is also useful for evaluating the effectiveness and disease progression. Shuttle walk test is a field-based exercise assessment designed to measure walking capacity, particularly individuals with chronic respiratory and cardiac condition. It is similar to a laboratory-based cardiopulmonary exercise test, but is performed in a simpler setting requiring less equipment. The primary outcome measure of the shuttle walk test is the distance walked. It is an externally paced test requiring individual to walk between two markers placed 9 or 10 meters apart. The walking pace is detected by the auditory beeps played at regular intervals. The walking speed increases progressively each minute. The test ends when the individual can no longer maintain the required pace or stops due to shortness of breath or fatigue. The total number of shuttle completed is recorded and converted to meter. The interpretation is a higher total distance walked indicates better functional capacity. Minimal clinical importance difference for the patients with chronic respiratory disease, a change of 35 to 58 meters is considered significant. Other sources suggest a change of 47.5 meter. Stair climbing test, a functional exercise test that evaluates a person's ability to climb stairs, providing insight into their lower body strength, power, and overall functional capacity. A shorter time to complete the stair climbing test generally indicates better functional capacity. Interpretation focuses on time taken, distance covered, and the presence of any symptoms like breathlessness, chest pain, and can be valuable to it can be a valuable tool for predicting postoperative complications and overall survival. This is the summary of the American College of Chest Physician guidelines. Assess the ABB1 DLCO if more than 60% low risk except mortality less than 1%. If between 60 to 30% stair climbing or shuttle walk test. If stair is more than 22 meter or more than 25 shuttle, then low risk. If between less than 30%, then a cardiopulmonary exercise testing. If in that stairs is less than 22 meter or less than 25 shuttle, then we should do cardiopulmonary exercise testing. And if cardiopulmonary exercise testing showing maximum oxygen consumption is less than 35% to 75%, then moderate risk. If less than 35%, then high risk for mortality. Cardiopulmonary exercise test is the criterion standard for the preoperative evaluation of the candidate for lung resection. It is performed in a controlled environment with continuous monitoring of various cardiologic and pulmonary parameters. It is a standardized and easily reproducible in different settings. And in addition to the maximum volume of oxygen consumption, which certainly remains the most important, it can provide several other direct and derivative measures that can be used in case of limited aerobic reserve to precisely identify possible deficit in the oxygen transport system. Smoking cessation retrospective studies have demonstrated a reduced number of pulmonary complications as well as reduced rate of perioperative mortality for non-smokers as compared with current and former smokers, with longer abstinence associated with favorable trend. So this is the overall guide algorithm ERS algorithm for preoperative functional evaluation, which includes RCRI more than two or any cardiac condition requiring medication, a newly suspected cardiac condition, or inability to climb 2 flights of stairs. If it is no, then lung function test to be done. If it is yes, then cardiac consultation with non-invasive cardiac testing treatment as per the AHA guideline should be done. If needs coronary intervention, CABG or PCI, postpone the surgery for more than 6 weeks. If continue with ongoing cardiac care, then institute may need that new medical intervention like beta blocker, anticoagulants, or statins, and then do lung function test. And RCI high risk surgery include lobectomy or pneumonectomy, includes ischemic heart disease, prior heart failure, insulin dependent diabetes, and previous stroke or TI, and serum creatinine more than 2 milligram per deciliter. Mm. Resection remains fundamental to the curative treatment of lung cancer. The basic approach to every surgical resection includes confirmation of the diagnosis and stage, complete resection of the tumor, and clearance of the locoregional lymphatic drainage through removal of lymph nodes. In patients without preoperative tissue biopsy, wedge resection may be performed with frozen section pathological evaluation before formal resection. Once resectability is determined, the tumor burden and the patient characteristics determine the extent of surgery to be performed. This may be anatomical or non-anatomical. Anatomical resection involves resecting the lung parenchyma in accordance with the branching of the pulmonary vessels and bronchi. This includes segmentectomy, single or multiple segments, lobectomy, bilobectomy, and pneumonectomy. In non-anatomical resection, like wedge resection, the target lesion determines the extent of resection. A comprehensive nodal assessment must be performed in all the pulmonary resection, regardless of the extent. This can include either systematic sampling or a complete dissection. This is the image of the wedge resection, segmentectomy, and lobectomy, sleeve resection, and pneumonectomy. Surgical principle and management. This includes following points like completely remove the tumor and all interpulmonary lymphatic drainage. The standard procedures for non-small cell lung carcinoma resection are anatomic lobectomy, sleeve resection, bilobectomy, and uncommonly pneumonectomy. Not to transgress the tumor during the resection in order to avoid the tumor spillage. Make an effort to perform en bloc resection of adjacent or invaded structures rather than discontinuous resection. Perform frozen section analysis on the bronchial margin and in any other margins in close proximity to the tumor. Perform extended resection when possible if a positive resection margin is encountered. Then play the surgeon has to play an active role in orienting the pathologist and marking any concerning margins to improve the accuracy. Remove or sample all accessible mediastinal lymph node stations for pathologic evaluation. These need to be anatomically and numerically labeled by the surgeon to enable precise pathologic staging in every patient. Surgical resection, selection of operative procedure. First one is lobectomy. It is the ideal operation for resection of the non-small cell lung carcinoma confined to a single lobe. The tumor and its lymphatic drainage, both pleural and central, are removed. Lobectomy is generally well tolerated and usually leaves sufficient volume to fill the pleural space. Sleeve lobectomy is a parenchyma saving procedure that involves resection of a lobe with a circumferential segment of the adjacent mainstem bronchus. It is indicated for the central tumor for which the alternative is pneumonectomy. Sleeve lobectomy is used when a negative bronchial margin cannot be achieved with standard lobectomy. Construction of a precise, properly oriented bronchial anastomosis adds to the technical demands of the procedure. Accurate frozen section analysis of the resection margins is mandatory. For tumors that involve the pulmonary artery, pneumonectomy can be avoided by the use of pulmonary arterioplasty. Pneumonectomy is typically performed for central tumors and is appropriately performed if lobectomy doesn't provide complete resection and the loss of an entire lung will be tolerated. Indications are extensive involvement of the mainstem bronchus, adherence to the proximal extrapericardal pulmonary artery, and an upper lobe lesion that invades the pulmonary artery to the lower lobe. Bronchoplasty can be used to obtain negative margins on the airway and pulmonary artery in order to avoid pneumonectomy. Modification to a standard pneumonectomy includes intrapericardial dissection and ligation of the pulmonary vessels, supraaortic pneumonectomy on the left, and the tracheal sleeve pneumonectomy. Completion pneumonectomy is widely known to be associated with even higher morbidity and mortality. It is usually performed for progressive or recurrent benign disease, for recurrence of a malignant tumor, and for complication after lobectomy. The mortality rate for the pneumonectomy around 21%. Segmentectomy is an anatomical sublobar resection that may increase resection rates in the patient with stage 1 non-small cell lung cancer and poor pulmonary function. It is technically more difficult than lobectomy because of the lymph node dissection required and the anatomic division of the parenchyma and the complexity of the procedure for tumors that are larger than 2 centimeter. Segmentectomy is performed for non-small cell lung cancer and small peripheral tumors, most frequently in the superior segment of the lower lobe, the lingula, and the apicoposterior and the anterior segment of the left upper lobe. Segmentectomy remains controversial due to the question of increased local recurrence and reduced survival compared with lobectomy. Segmentectomy preserves pulmonary function, FPB1, and maximum voluntary ventilation without compromising survival. The 4-year survival rate of segmentotomy 67%, while lobectomy 62%. Importantly, the segmentotomy group have significantly worse preoperatively pulmonary function, but equivalent survival. The parenchyma is divided just beyond the burden segment, and the intraoperative frozen section of the segmental, hilar, and mediastinal nodes are used to confirm N0 status. A lobectomy is performed if the margin of lymph nodes are positive. Wedge resection is a non-anatomic procedure that is used to accomplish complete resection with minimal sacrifice of pulmonary parenchyma. It is used primarily for patients with limited lung function as a result of increasing disease, emphysema or ILD, and for synchronous or metachronous tumors in patients who would not tolerate the lobectomy. The major problems with wedge resection as a primary treatment for non-small cell lung cancer are an increase in local recurrence despite negative margin and a trend towards reduced survival. Postoperative local radiation therapy has been used in an attempt to reduce the local recurrence rate after wedge resection. However, external beam radiation further reduces pulmonary function in this already compromised group of patients. Video assisted thoracoscopic resection. It has been used with increasing frequency for major lung resection. Two technologically advances that made non-rib spreading VATS lobectomy possible were the improvement of optical system and the advancements of linear staplers. Proponents of VATS lobectomy for small peripheral tumors state that it decreases pain, preserves pulmonary function, reduces the systemic inflammatory response, and leads to an earlier return to normal activities. It is important to remember that VATS represent a new approach rather than a new procedure, and it doesn't change the indication for surgical resection of non-small cell lung carcinoma. Absolute contraindication to VATS are inability to tolerate single lung ventilation, large tumor more than 4 centimeter, effused pleural space, and established N2 disease. Complications include bleeding, tumor implantation at port site, increased rate of bilobectomy for right upper lobe lesions due to technical factors of superior vein branch dissection. Lymph node dissection. Complete mediastinal lymph node dissection is the most accurate way to stage a patient's disease and to determine which patients might benefit from adjuvant therapy. Selected lymph node biopsy is a no systematic nodal dissection or biopsies are performed. Only suspicious lymph nodes are biopsies to prove N1 or N2 disease. The procedure is justified only to document metastatic disease when resection is not justified. Lymph node sampling. One or more lymph nodes are removed guided by preoperative or intraoperative findings that are thought to be representative. Systematic sampling means that a predetermined sampling of the anatomic lymph node station is performed. Systematic nodal dissection. The mediastinal tissue containing lymph nodes is dissected and removed systematically within anatomical landmarks. Lobe-specific systemic lymph node dissection. The mediastinal tissue containing specific lymph node station is excised depending on the lobar location of the primary tumor. Radical lymph node dissection includes for right-sided tumor example, all mediastinal tissue containing lymph nodes is dissected and removed within the anatomical landmarks. For left-sided tumors, the aortic arch needs to be mobilized to obtain access to the high and low paratracheal nodes. Extended lymph node dissection, bilateral mediastinal and cervical lymph node dissection is performed through median sternotomy and cervicotomy. Stage 2 cancer, lobectomy is the procedure of choice for stage 2 T1 or T2 N1 disease. The incidence of local and regional recurrence after complete resection of stage 2 lung cancer is reduced by the postoperative administration of radiation therapy. However, the radiotherapy has no impact on survival. T3N0, T3 tumors are lesions of any size that invade the chest wall, diaphragm, mediastinal pleura, or are located within 2 centimeters of carina without carinal involvement. Because of the favorable survival after surgical resection of T3N0 tumors, they have been reclassified as end-stage 2B disease. These tumors extend to invade parietal pleura. Local invasion can involve muscle ribs of the chest wall. With the chest wall invasion, many of these patients are candidates for en bloc resection. Factors that influence survival of these patients include completeness of resection, extent of chest wall invasion, and the presence of regional lymph node metastasis. Stage 2B includes who benefits from surgical resection are those who have central tumors within 2 centimeters of carina but without actual carinal involvement. Most of these lesions are resectable, but mediastinal nodal disease must be ruled out preoperatively. Pneumonectomy is the most common resection offered for these three tumors, but sleeve lobectomy needs to be considered whenever it can accomplish a complete resection. Patients presenting with tumors that invade mediastinal pleura have a relatively poor prognosis when treated by surgery alone. Radiation therapy has been used as an adjuvant therapy after both complete and incomplete resection of T3 disease. Stage 3 disease patient with ipsilateral mediastinal lymph nodes and T3 tumors or less have stage 3A disease. Stage 3B disease includes multiple tumors in the same lobe and tumors that invade adjacent mediastinal organs like T4, and stage 3B also includes contralateral mediastinal lymph node spread N3. Stage 3 disease with N2 metastasis to ipsilateral mediastinal lymph nodes. Uh, these are the most frequent deterrent to cancer cure despite an apparent localized presentation. And these are of two types: clinically undetected N2 disease. These are resectable if N2 disease is discovered by the pathologist. Adjuvant therapy may be considered after resection. However, chemotherapy is often poorly tolerated after major pulmonary resection. Clinically evident N2 disease, unresectable one. The goal of the preoperative staging is to determine which patients will benefit from initial surgery and to identify patients that may benefit from the induction therapy and subsequent resection. A combination of CT, PET, and mediastinoscopy is important to identify patients with stage 3A disease. If N2 disease is discovered preoperatively, most patients receive definite chemoradiation. However, if the nodal disease and primary tumor appear to be resectable, induction therapy may be considered because of the result of primary resection is poor even for well-selected patients. Stage 3B disease T4 or N3. T4 disease carinal involvement. Lesions that extend up to and invade the carina have a much poorer prognosis than those in the main stem bronchi. Pneumonectomy with tracheal sleeve resection and the direct reanastomosis of the trachea to the contralateral main stem bronchus is the only option to obtain to complete resection. This is a technically demanding operation and is reserved for younger patients with few medical comorbidities. Mediastinoscopy is essential to identify those patients whose cancer is completely resectable. Induction chemotherapy has been used to improve the complete resection rate and doesn't appear to increase operative mortality. T4 pleural tumors with a malignant pleural effusion have an extremely poor outcome after the surgical resection. Pleural pleural effusions detected by staging evaluation must be investigated. Thoracocentesis with cytologic examination or pleuroscopy can prevent a non-therapeutic resection. If an effusion is discovered at the time of thoracotomy, the fluid is to sent for urgent analysis. The problem with the surgery for this disease is that complete resection is almost impossible. N3 disease, contralateral mediastinal lymph node metastasis represent N3. Patients with N3 disease have a very poor prognosis and long-term survival. N3 disease is an absolute contraindication to surgery except as a part of an investigation procedure. Recently, induction therapy has been evaluated in the treatment of N3 disease. Stage 4 disease, distant metastasis diseases are not curable by surgery. Solitary brain metastasis, almost 25% patients with stage 4 have brain mets. The survival time for patients treated with steroids alone is 2 months. It improves to 6 months with whole brain radiation. Aggressive treatment of solitary brain mets may involve either surgical resection or radiosurgical ablation. Patients may be considered for treatment if they are medically fit, have completely resectable brain mets, have no evidence of other systemic disease, and have primary non-small cell lung carcinoma confined to the lung. The 5-year survival of uh, 5-year survival with the brain mets approximately 20%. Post-operative whole brain radiation is frequently used to help sterilize the tumor bed. Isolated adrenal mets, solitary adrenal metastases are detected with increasing frequency because of the preoperative CT and PET scanning. Highly selected patients have undergone resection of adrenal mets from non-small cell lung carcinoma with curative intent. The overall 5-year survival is 20%. Survival is improved if N0 in N0 patients, but tumor histology, synchronous versus metachronous presentation, and ipsilateral versus contralateral location do not affect survival. Radiotherapy in lung cancer. Patient selection for radiotherapy, patient-related factors depends on lung function. For FBB1 alone, not a contraindication. We have to assess the risk versus benefit of radiation pneumonitis. Comorbidities like COPD tolerates radiotherapy well. Autoimmune disease and cardiac condition increase the toxicity. Age and frailty. Age alone is not a barrier. Assess functional reserve. Use frailty tools to guide decisions. Medication, ACE inhibitor or statins may reduce toxicity, not yet part of routine selection. Molecular markers like elevated CRP, interleukin 6 are poor prognosis. SNP is linked to toxicity, not clinically validated. Smoking, active smoking decrease survival and local control. Strong emphasis on cessation. Nutrition, malnutrition, cachexia increase toxicity, decrease outcomes. Early dietitian involvement and advised. Fatigue and activity. High fatigue reduces radiotherapy tolerance. Physical activity improves symptoms and quality of life. Repeat radiotherapy possible in selected recurrent cases. Careful dose planning required. Tumor related factor. Tumor stage, early stage 1 and 2 suitable.
Shruti,
Yes, sir.
do you have many more slides?
I have yes, 18 slides.
No, we will do this radiotherapy and adjuvant chemotherapy in the second class. Okay.
Okay, sir.
This will become too long, and then I don't think people will have enough attention for this. Okay.
Okay, sir. Okay,
We
sir.
will stop it here, and then I have a
Okay,
few
sir.
comments. All right.
Yes.
It was an extensive procedure, presentation. Now, a few things that you all should know, basic things. Once you see a patient with a suspicion of a lung cancer, first thing is, as you said, chest X-ray. In the chest X-ray, the two things that are to be mentioned, and whenever you see a nodule, you want to know whether it is a benign nodule or a malignant nodule. First of all, you have to differentiate a nodule from a mass. A nodule is less than 2 centimeters, and anything more than 2 centimeters is called a mass lesion. Okay. Then when you look at the chest X-ray and the nodule or a mass, you look at the margins. If you have smooth margins with normal lung tissue around it, it is usually a benign lesion. Whereas if you have spiculated margins and also involvement of some amount of parenchyma of the lung, like pneumonitis or something, then you have a suspicion of malignancy. That is the first thing. Next investigation that you're going to do is a CT. In CT, it will delineate the mass lesion a little more specifically, and you can also detect nodes and metastasis many a time. Okay, of course, if you are doing only a HRCT of the chest, you don't know the distant metastasis. So you will delineate whether this is, again, it points to a benign lesion or a malignant lesion. The other thing that will tell you is the tumor doubling size in time. So if the tumor is growing rapidly, that means it is more likely to be a malignant lesion rather than a benign lesion. So and then also presence of calcification. Calcification is usually a chronic disease, and most likely a sequelae of tuberculoma or any other chronic disease, benign lesion. However, there are certain tumors which can also give rise to calcification, and that will be proved by your biopsy. The next investigation is the PET. PET is usually done for detecting metastasis and also for staging. Okay, if there are distant metastasis, PET is usually done to know whether this patient is operable or not. That is the primary indication for a PET scan. Then, of course, you didn't mention anything about the MRI. And MRI is also useful if you want to know whether the patient is operable, if there is any involvement of the surrounding structures, especially the mediastinum, the pericardium, or the great vessels. So in such a situation, MRI will be of much use to you to decide whether this patient is operable or not. Okay. Then you did not mention anything about rose. Do you know what rose is? Not a lady, but it is called rose. It is rapid on-site evaluation of a biopsy specimen or a bronchial washing or a bronchial biopsy. It is done next to the bronchoscopy suite, and where the pathologist will immediately see whether there is a representative tissue and whether that can be useful for diagnosis of the cancer. Otherwise, you may have to repeat your biopsy. So that is called ROSE, rapid on-site evaluation. Okay, then we have then you talked about TBNA and EBUS. What is the difference between TBNA and EBUS? TBNA is a blind needle biopsy through the bronchial wall into the tumor tissue. Okay, so you can many a time, because the pulmonary artery is very closely associated with the trachea bronchial tree, you can injure or you can puncture the pulmonary artery. So TBNA is a blind procedure, whereas EBUS has an ultrasound guided, and you can specifically look at the ultrasound and biopsy the node or the tumor specifically. EBUS also has a corollary. It is called EUS, that is endoscopic ultrasound, and that is done through the esophagoscopy. And esophagoscopy to sample the stage 9 and 8 and 9 nodes, or rarely station 6 and subcarinal station 7 nodes. So those are the things. Another important differentiation that you all should know is BAL. BAL means bronchoalveolar lavage. And lavage means you inject saline almost 150 to 300 ml, aspirate that, and then look for different cytology. This is not used for usual malignant lesions. This is used for basically interstitial disease, or more specifically alveolar proteinosis. So don't confuse BAL from bronchial washings. In bronchial washing, you inject only about 10 to 20 ml of saline and then aspirate it, and then spread it on a slide and look for cytology. So most of the time when we are looking for some malignant lesions, it is bronchoalveolar washing and not BAL. Alveolar lavage is a separate thing. Then again, when you said about thoracocentesis, when you aspirate thoracocentesis, you are supposed to aspirate the entire volume, or at least about 200 to 300 ml of the pleural fluid that is collected there, and then centrifuge that sample and then send it to the pathologist, or send the whole thing to the pathologist and they will centrifuge it in their lab and then look under the microscope for malignant cells. That is important. Just aspirating 20 ml of pleural fluid and sending it to the pathologist is of no use to them, and you will miss many diagnoses, and especially because it is important to know that pleural effusion, malignant effusion, means it is a stage 4 disease. Okay. So these are the things that you should know when you're doing a diagnostic evaluation of a lung cancer. Then comes the stage grouping. You mentioned the whole thing about TNM classification, and there have been various modifications, and the latest modification is 9, where they have differentiated T1 into T1A, B, C, and T2 also to A, B, depending on the size of the tumor and the distance from surrounding structure. Why this came about? Because each one of those stages has got relevance for the long-term survival. So stage 1 and stage 2 are important. And then early stage grouping. So when you are doing stage, and then of course the N2. N2, the recent modification is N2A and N2B. Earlier it was only N1, N2, and N3. N2A is single station and N2B is multiple station. And this is important in the treatment planning. N2A, if there is a resectable tumor, and N2A, that means it's a single station, you can still offer them surgery and a curative treatment. Whereas N2B means multiple lymph node stations in the mediastinum. That means it is not fit for surgery. So here there is a controversy. All N1 lesions, surgery is the treatment of choice. All N3 lesions, surgery is not recommended. And N2 is the controversy, where N2A will be surgery, N2B will be no surgery. So this is something that you should learn or remember all the time. Understand? Then you have stage 1, 2, 3A, 3B, and 4. Now, 1 and 2 are called early lung cancers, and surgery is the treatment of choice. 3B and 4 are advanced lung cancer, where surgery is not recommended. So these are clear-cut margins. 3A is controversial, and that you have to individually see whether the patient is operable or not by various other additional scanning like the PET and MRI to see whether you can safely remove the tumor. So 3A is a controversial topic, and that should be discussed with the radiologist and with and then see how much expertise you have in resecting a 3A lesion. But 1 and 2 definitely surgery, and stage 3B and 4 are definitely no surgery. In 1 and 2, again, there is a controversy whether you're going to do a wedge, whether you're going to do a segment, whether you're going to do a lobectomy, and that can be a bigger, much different topic for discussion a little later on, because there are a lot of controversies about that, and there are a lot of articles that are published deciding what to do. And in stage 4, sometimes you may have a resectable tumor. That means it may be a very small tumor, but there is a distant metastasis. In such a case, you can still offer surgery, and that is when you have an oligometastasis. That means there is only a single met in the brain or in the adrenal. So in the brain, if there is a single metastasis either detected by the neurosurgeon before and then they also found an incidental lung cancer. The treatment of choice is you have to do the brain first and then the lung resection. If there is a detection simultaneously, then both the lung and the brain met are seen together, then again you do the brain first and then the lung lesion. This is the sequence that you have to remember. But if you have had a resection of the lung and subsequently you have an isolated brain met, which is operable, then you can do that as a later procedure. So these are the three things that happen when you have a brain met. If you have an adrenal met along with the lung cancer, then you can still operate them simultaneously. So this is the thing in 4A, that is a single metastasis, as compared to 4B, where there are multiple metastases. When there is multiple metastasis, you don't do surgery. You understand? So these are the basic principles that you should know before you embark on any surgical management. One is staging, whether this patient is operable. Then comes the evaluation, as you extensively said, preoperative evaluation, whether the patient is fit for surgery, and then you do the surgery. So this again comes to my three primary questions, which you all know: whether this patient requires surgery, whether the patient is fit for surgery, and whether your surgery is going to do him good or you're going to make him worse. These are the three questions to be answered in every case that you see, whether it is lung cancer, whether it's thoracic, whether it's cardiac, everything. Understand? So that is the basic principle. Once you know the basic principles, then you can work around and different things. And then you can also, if there is a controversial finding or if there is some confusion, then you can always look for the best option and then decide whether to operate or not to operate on this patient. The next important thing that comes is the question of neoadjuvant therapy, whether you're going to use chemotherapy, radiotherapy to downstage the disease and still offer surgery, or you have to have adjuvant therapy, which you will follow up after your surgery and you found that there is an N2 disease, and then you have to follow up with chemotherapy or radiotherapy. So that can be done as a separate class because it becomes too extensive. Any questions? Everybody is sleeping. Okay. All right. Thank you, Swati. Then you do the radiotherapy, chemotherapy part, and then also the newer chemotherapy and immunotherapy as a separate this thing. That will not be so much important for us as surgeons, but we should know when to send them for pre-op neoadjuvant or post-op adjuvant therapy.
Yes.
Okay?
Yes, sir.
All right. Thanks, everybody.
Thank you, sir. Thank you, sir.